Hello, everyone. I'm Traci Arieli, end-of-life doula and founder of Comforting Closure. Welcome to the show. Today, we're going to explore a topic that most do not want to talk about: hospice. Hospice is misunderstood and often considered as a last resort. But hospice can significantly improve a person's quality of life, and in many cases, it can even extend it. A study published in the Journal of Pain and Symptom Management found that the mean survival rate was 29 days longer for hospice patients than for non-hospice patients. And with people that had chronic heart failure, the mean difference was 81 days, about 2.5 months longer. My hope for today's episode is to dispel some of the common fears and misconceptions and help you understand how hospice can be a powerful support system for both patients and their families. To help us, I'm honored to be joined by Angela Nova, who is a nurse and palliative and hospice care consultant for the Hospice Foundation of America. Together, we'll talk about what hospice really is, how it helps, and why it's something that people should consider sooner rather than later. Angela, welcome, and thank you so much for being here today.
Thank you for inviting me. It's a pleasure.
Can you start off and tell us about your journey to become part of the Hospice Foundation of America?
Yeah, it was somewhat of a long and winding road. I've been in healthcare in one form or another for 30 years now. Most latterly, before joining HFA, I worked as an attending in nursing homes and in skilled nursing facilities. And during my tenure in those facilities, I witnessed a lot of patients who were rebounding from the emergency room back into the nursing home, back to the emergency room. And it seemed like this was happening with alarming frequency. We would be discharging and readmitting, and nothing really productive was being done for them in the emergency room or during their hospitalization. And when I looked more closely at that, the reason they were being sent out as frequently from the nursing homes as they were was that they were all full code. They were old, very frail, unable to perform any activities of daily living for themselves, sometimes demented, and certainly for the most part, at what could be anticipated to be the end of their life. And yet still they were going through this cycle of hospitalization and readmission into skilled nursing homes and other nursing care facilities. So that got me interested in the whole topic of having discussions with patients and their family members about really considering end of life care as an alternative to bouncing backwards and forwards from the hospital, which was often sort of detrimental to their health and psychological health, certainly. And nothing was really being done to help them in any significant way. And certainly most of them didn't want to live that way, but didn't understand that there was an alternative care that they could opt into. And many people I spoke with in those roles had never actually had any healthcare provider sit down with them and explain prognosis and explain the options and involve them in that discussion. I was oftentimes the first person to have spoken to them,
Mm.
despite the number of times they'd been hospitalized and despite their fragile health conditions.
So, after you figured this out, when did you discover the HFA?
Well, I finally decided that I was going to look more into hospice through all of my training, even in nurse practitioner school, and I graduated from a very highly regarded, highly rated brick and mortar school. They didn't really cover a lot about hospice in any way, shape, or form. I've always been sort of, I guess, a proactive learner. And so I enrolled myself in a lot of college courses and eventually became board certified in hospice and palliative care so that I could have some foundation and legitimacy to the knowledge and experience I'd gained through private practice. Um, so eventually I transitioned to working for a hospice. And I was completing their face-to-face reevaluation for continual benefit visits with people in the home and working as an attending in their inpatient hospice house. Um, and frankly, I loved the work. I truly felt like I found my vocation with that work, but I did succumb to the burnout that afflicted a lot of other bedside caregivers during COVID, and didn't feel that I could continue giving my best at the bedside, and decided to refocus my career into um, an organization where I could speak to a broader audience and educate about end of life care and hospice as somebody who was both um, been an attending in a hospice care environment and has been a loved one for people who were cared for under hospice at their end of life. And I think that's sometimes important in making those connections and really understanding the intricacies of what life on hospice can really look like.
So, we're going to start with the basics. What exactly is hospice care and how does it differ from other types of medical care?
Okay, so there are a lot of things that hospice care is, but essentially it's a philosophy of healthcare provision. Um, all medical people, nurses, everybody in the healthcare field is trained to save people, to all of the latest ways we can do that. And we're really trained and medicalized into problem solving and fixing people. Hospice care is a philosophy where we're not necessarily doing those aggressive interventions. We have accepted that end of life is near, and we want to focus more on quality of life and getting a circle of people around us that can optimize that quality of life by managing symptoms aggressively, by no longer seeking out aggressive or invasive interventions that are designed to prolong life, but it's sometimes a very sort of high cost. Physically, emotionally, mentally, and psychologically, and financially. It's not cheap to be terminally ill in America today.
Unfortunate. What key services does the hospice benefit provide to patients and to their family? What should they expect? What should they not expect?
Mhm. Most people that I've spoken to through HFA and the helpline and emails that we receive from people have much higher expectations in some realms for hospice than is the reality. Um, Hospice providers and the hospice industry, and I use that word accepting that a lot of people hate that word, but it is an industry. It's a sector of healthcare. We've spent a lot of time and effort educating members of the public that hospice care is no longer for end of life. Because that was a very common myth. People thought you had to be actively dying in order to receive hospice care. So we promoted the fact that it's not just for end of life care. And now, unfortunately, a lot of people think that if you have a mom or a dad or a close relative or loved one that has dementia, you can enroll in hospice care immediately and receive all of the benefits, and that simply isn't true. So the primary criteria for hospice eligibility remains, and it always has been, a prognosis of 6 months or less. And that's if the disease runs its natural course. There are other disease-specific requirements to be considered when determining the prognosis and the anticipated life expectancy. But that remains as true today as it always has remained. Another thing that is a myth that many, many people believe is that the hospice Medicare comes in and takes over care 24/7 and will put you in a nursing home and everything is paid for. it was never designed that way. The Medicare hospice benefit was always designed to supplement the care already being provided by friends, family members, loved ones, privately paid aides, or the staff members who have been caring for your loved one in the nursing home that has become their home. We supplement that care in a large and varied number of ways, but hospice directly does not pay for room and board. So they're the two main misconceptions that sort of managing those expectations can be a challenge for people trying to understand the benefit. What we do provide is time and services of an interdisciplinary care team. And that includes visits to the patient's location, to their home, by hospice physicians, nurses, nurse practitioners, medical social workers, home health aides, chaplain and spiritual advisors. And we also have wonderful teams of volunteers and home health aides who go in on regularly scheduled visits to help with activities of daily living or hygiene and providing bathing and shower services. And possibly helping with a load of laundry if that will help ease the caregiver burden. Hospice also provides all of the medications needed for the primary hospice diagnosis. So, whatever the reason you were admitted to hospice care for, they provide everything related to that care, medication wise. They also provide all of the medications for symptom control, pain relief, all of the durable medical equipment that people need to be able to die at home comfortably, whether that includes a hospice bed, wheelchairs, walkers, medical supplies, oxygen equipment, even Hoyer lifts, if that would enrich the patient's quality of life to allow them to get out of bed safely. We also cover the services that are involved with all of those terminal illness and symptom management. So anything related to symptom crises that can happen in the very late stage of the disease progression, we're available for that. We also provide short-term respite care, where the patient can be admitted to a hospice house or a specifically designated unit within another healthcare organization. Can be a special unit even in a hospital where or a skilled nursing home. It's somewhere where the hospice organization has contracted for your loved one to go for 5 days at a time so that their caregivers and family can take a break and just breathe or take care of their own medical needs or go on vacation or go to a family wedding, and they don't have to worry that nobody's home to look after their loved one. And another important feature that's useful and very beneficial for a lot of families is the grief counseling that's provided for up to 13 months after death. What that grief counseling looks like varies from agency to agency, but the family will have a phone number that they can use for support during that critical 13 months post-death.
Yeah. Now, what when we talk about these services, you mentioned that hospice isn't there 24/7, that is a myth. And it is a big surprise. That's the surprise that I see the most, that people from the hospice team aren't there all the time. And I always tell people what they can expect in my experience. Not all hospices are this way, but what I've experienced, that, when they get into hospice, depending where they are on their end of life journey, that they can expect once a week, 45 minutes to an hour. When they are starting to go through that journey, it could get to twice a week, 3 times a week. And then when they're actively dying, that last week or so, last week to 2 weeks, they can actually expect, hopefully, every day a visit, 45 minutes to an hour again. But most likely the hospice team, it's very rare when a hospice team is there when a person passes away, just because of timing. And it's not that the hospice nurse, the hospice team don't want to be there, or because they would want to be there. They do want to spend as much time with each family and with each patient as possible. But it's the way I think our Medicare system is set up, with which is a problem. With the hospices get paid per patient and not by how much time they're spending with each patient. And so I find that the Medicare suggestions or the rules for hospice are really lacking as far as how much time they need to spend, or even with bereavement, how many sessions are mandatory. And it's unfortunate. I think it's outdated is what it is, because people are living longer now. So I think it's really just outdated and needs to be reassessed.
Mm-hmm. I agree. And you know, no legitimate hospice organization wants to deprive their patients or those families any time at all. We would love to be there sitting vigil at the end. But it's simply not possible. There are a lot of factors involved in that too. A lot of them financial, because you're right, hospice only gets paid per day per patient, and nothing up front. A lot of people think that, they read about the annual caps in payments and assume that the hospice agencies get paid that in advance, either a year in advance or 6 months in advance, and that generates a lot of theories about, well, it's better if you die sooner because then they make more money. Anyone who's ever tried to bill Medicare for anything will know that they do not pay anything up front, and you will wait months for payments. So it doesn't behoove hospice care providers not to provide services, not to be there at end of life, and not to want to keep you as hospice patients as long as possible. So, so that you can benefit for those services. But people are unpredictable. They're unpredictable in life and they're unpredictable in death. And with the best will in the world, we just cannot put somebody with a patient at bedside for hours, potentially days, sometimes weeks, because they're just simply that fragile that they could go at any time, and we don't know when, and we don't know what necessarily will precipitate that. We're all end of life care specialists and professionals, but if somebody tells you they can predict exactly when somebody's going to die, I'm sorry, but I would have issue with that. I have visited many patients in their home to do their every 60-day assessment for continuation of benefit, and said to myself, well, I guess I'll never be going there again. And there I am 2 months later. And it's like, how could this person possibly be alive? But you cannot anticipate the resilience of these frail people, mostly in their 90s, they're just so unpredictable. And bless them. It's, it's their death and they will go when they want to. And, the textbooks are simply thrown out of the window at that point. I mean, the best we can do in the current structure is, hospice may not be there for you 24/7 at bedside in your home, but we are there 24/7, 365 with the hospice hotline for your agency, whoever your hospice provider is. And so many families, that alone, given all the shortcomings of what we can and cannot provide, and the restrictions, the legislative and financial restrictions that we have upon us, that one thing can make a huge impact in the caregivers' lives. Simply knowing that if something happens that worries them at 3 o'clock in the morning, they can call and speak to a nurse. They maybe won't get through immediately because that nurse may be on the phone with somebody else who's also 3 o'clock tends to be the the prime time for healthcare emergencies across the board. But they will call you back and they'll talk you through that and they will walk you through that, tell you what is happening and tell you what you have in your home, because we've prescribed all of the medications, what you can do to give your loved one relief immediately until we can get there. We can't guarantee we can get there in 10 or even 30 minutes, but we should be able to tell you how you can help your loved one in that immediacy to provide them comfort until we can get to you. And that's kind of a big deal for many of the families who've been caregivers, sometimes for months and years, just to have somebody have their back and tell them, you're doing a great job. Here's what you can do with this symptom, and we'll be there when we can, but this should help them for now until we can get there. It's enormous. It's like a weight lifted from them.
I agree. As a doula, I feel like I'm an extension of the hospice team, and I really believe as important as a relationship with the client and their family is a relationship that I have with the hospice team. Because I do have hospice teams calling me and asking me to check on a client. I love
And we
hospice
love that.
Yeah, and I love hospice nurses. They are my heroes. They're amazing. About 90% of what the hospice nurses do is education. It really is educating the family, educating the person who's in bed as to what they could expect. I mean, they are fantastic. Unfortunately, as we know, humans, it takes, 7 or 8 times before we hear something for it to even stick. So sometimes it can be difficult, but having someone on the phone on the other line is really key, and it is a wonderful benefit.
Hmm. Yeah. And I agree. And I don't think it's that people are not listening when we
Yep.
try to educate them. And it can be a little frustrating. And it's like, well, I told them that at my last visit, but we all in the back of our heads understand that this is one of the most stressful times of their lives. And how receptive are we? Would we be if we were in the same position? And I have to tell you, I've spent many years doing this, and I've been in healthcare, like I said, for over 30 years. But when it's me or my loved ones who are in a medical crisis, um, I'm not a medical professional at that point. I'm a loved one who's panicked, distracted, exhausted, um, and not really registering everything that's going on because I've reached my mental capacity, my physical, sometimes my financial ability to just keep going. And so we're all hearing just snippets of what being said. So you're right. It takes a lot of reinforcement. I mean, what we can do medically for these patients is limited. We're
Yeah.
managing symptoms, okay, but we spend, I would say the ratio is probably 9 to 1 hours educating, listening, just supporting.
Yep. How do people access this care? Who do they need to talk to in regards of starting this process?
There's more than one way you can access hospice care. Frequently, it's through referral from a primary care physician. The primary care physician, who's sometimes been with the patient and their families for many years, will broach the topic when they see that their family is struggling with managing the patient and they've run out of medical options or there are very few medical options left. They will suggest it and they'll refer to hospice in the same way they would any other specialty. If you sprain your ankle and go to your primary care, he's going to refer you to an orthopedist most likely to make sure that everything is okay and you don't need a surgery and it's not broken or you need physical therapy. Hospice is the same. Hospice is a medical specialty. It's not outside of the medical profession. It's a specialty the same as any other. So many of the referrals come from the physician, and they will send it into a local hospice organization that they have used in the past and they know and trust. Sometimes they've used that agency for their own family members and certainly have referred other patients to that agency. A lot of referrals come through hospitalization in those instances where patients are showing up in the emergency room frequently and the hospital staff are acknowledging that there's not much they can do but put a band-aid on the problem essentially and send them back home, whether that's a nursing home or home. And then a week later the patient has another exacerbation of symptoms and he's back in the hospital. If it's a good hospital and they have diligent staff members who are open to making a referral to hospice, that is another avenue that a lot of patients come into hospice care when the hospital staff refer to their palliative teams inside of the hospital for an eligibility assessment and at least broach that topic with the patient and family members that again this may be an alternative that they want to consider, particularly if they've expressed that we don't know what to do. We're here every week, nothing is getting better, what do we do? How can we help our loved one not to have to endure this every couple of weeks or every couple of months? And people can also self-refer. There are a surprising number of frail elders who have not seen a physician in many, many years. And the family visits them usually around the holidays. Thanksgiving and Christmas can be pivotal, and suddenly their loved one is very, very much diminished from the last time they saw them at the holidays a year ago. They see signs of struggling to feed themselves or care for themselves. There may be rotten food in the refrigerator. The home may be dirty and disheveled, as may the patient. And those patients don't have anybody, a physician, who can refer them to hospice care. If that is the case, a loved one, a power of attorney, a neighbor even can call a hospice organization and say this and tell them this person isn't doing very well. They don't have a physician. They have not sought out any kind of medical care for years and they're declining. I think they may be in trouble. I think they may need hospice assistance. That agency will come out to do an eligibility assessment on them and can directly admit them without that referral.
Yeah.
And Medicare pays 100% again for hospice services, not room and board necessarily, but hospice services. Medicaid offers similar coverage within different states. It can vary a little bit between the different states because Medicaid is statewide and Medicare is a federal benefit. Veterans can receive hospice care for no charge, and even people who are who have no insurance, no income, no means of private paying for any kind of care can oftentimes receive charity care from hospice providers who raise funds for those cases so that they can offer charity care to members of the community who couldn't afford it or wouldn't have access to it any other way.
Do you find that there is still that doctors are still hesitant to
Yes.
move yeah, and so what can we you're like, yeah, so what can we do? I mean, what can be done better so that doctors, I know doctors, they want to save lives. That is their mission. What can we do to change that? So it's, it's almost like doctors take it personally, like they failed.
Yeah. We all do. I mean, we've spent our lives. I didn't go into healthcare initially thinking I would be in hospice. I went into healthcare for the same reason everybody else goes into healthcare. right? You want to help people, broadly speaking, and you eventually train and diverge off into specialties, um, but you don't go into healthcare saying, one day I want to help people die. Um, I think you just don't. And if you do, maybe you should consider other options. But you don't. But I think anybody who spent any amount of time in healthcare understands that the system is a little bit broken, that we have medicalized dying, right? Despite the fact that the majority of Americans, at least, over 70% indicate, given the option, they want to die at home. So it's incongruous with the number of people who do actually die at home, right? Most people still die in the hospital,
Yeah.
uh, thinking that they can be saved. And we've sort of done it to ourselves. It's not just medical professionals that want to save everybody and think they can save everybody. It's the families and the patients. We've had so many medical miracles, even over my lifetime, that it seems impossible that people can't be saved because we've become so good at it. And our expectations have been broadened. Uh, you know, some of the interventions that we had that were meant only to be for acute care purposes, like feeding tubes, like IV feeding, they were never meant to be long-term options. They were meant to be post-surgical, post-critical care um, interventions that would temporarily allow somebody to recover back to their baseline. Same with IV fluids and electrolyte. They weren't meant to extend life beyond natural death. And yet we have people ask for them all of the time.
Yeah.
And all of those aggressive interventions that really don't prolong life and quality of life, but do prolong death
Yep.
in somebody who's already dying. Okay. They are wonderful life-saving therapies for people who have had trauma or are acutely ill or are post-surgery, and their organs, and they need to rest, and we can offer those, services. But it's a whole different aspect of what it means to care, um, when it comes to end of life patients. It isn't caring. One of the most pivotal times for me when I used to be a surgical technologist and a surgical assistant, and I was training um, in a community hospital. And I did an 8-month internship, if you will, at that hospital. And we were affiliated and adjacent to a local nursing home. And there was a lady that we did 3 surgeries on, 3 debridement surgeries on, for a horrible wound. And she was at end of life. And she shouldn't have been having surgery, but the family insisted on it because their intention was to heal the wound, because wounds in their mind were a sign of negligence and poor medicine. And every time they wheeled this lady into my operating room, she would beg us to leave her alone and beg us not to do the surgery. But we had to do it because that's what medical professionals do, right? There was a wound that was a good surgical candidate. The family wanted it. She didn't. Nobody asked her. And she endured the pain and the trauma that went along with that. And it was based on misconceptions about what end of life looks like. And I hate to bring up Jimmy Carter because I feel like a lot of people have been gratuitously, and I know I've given a lot of interviews about Jimmy Carter, but people were really shocked at his appearance during his wife's funeral. And it's like he's normalizing. This is what it looks like when you're old and frail and in hospice care. this is what it looks like, and we should accept that, embrace that.
Yeah. Well, all most Americans see is on TV and in movies where the person who's dying, it's beautiful. They look so healthy and they just take their last breath and close their eyes. And death
Yeah.
is not pretty. So, regardless of how it happens, this is the reality. We're human beings, our bodies shut down, and
Mhm.
um, yeah, we,
Yeah.
yeah. So,
It doesn't have to be traumatic
yeah,
in most instances, I want to say, but no, people don't die perfectly. They didn't live perfectly. They're not going to die perfectly. Um, and we need to accept that and come to terms with that.
yeah. Um, I found it fascinating. Just let's talk for a moment. But when we spoke before about the difference in how, what we do in America from where you're originally from, I think from the UK,
Yes.
and our expectations here. And if you could just tell us your experience, those differences, that would be. I found it fascinating.
Yeah, it really is a cultural thing. I mean, America, we have healthcare sort of on demand. For the large part, it's private healthcare, and we haven't experienced sort of socialized healthcare like they have on the National Health Service in England. And when we do hear about cases from the UK, they're usually highly controversial and revolving around small children who they show photographs of that just makes your heart bleed. And those horrible people in England are saying, no, we are not going to continue fetal care on this child. Um, and I think I certainly grew up understanding that having that health care was something to be very grateful for. And it was a very patriarchal system. And I'm not suggesting we should go back to not advocating for ourselves and our loved ones, but we had those boundaries that we knew that, you know, if we were beyond saving, there would not be attempts to save us. There would be every attempt to make sure that we were comfortable, but there would not be heroic measures if they were considered futile.
Yeah.
There is that expectation in America that heroic measures will be taken. Death has been medicalized. Um, there are a lot of misconceptions. Um, People in America, I think, are used to asking and demanding what they want and getting it, and not really stepping back and looking at things like quality of life and whether or not it's going to make things better. Is this intervention going to make my loved one's life better? Will it restore them to their past level of functioning? If the answer is no to one or both of those, then really what are we doing?
Yeah. We're extending their death is what we're doing.
Exactly. But there's a lot of guilt around that. And I think you have to be very comfortable with yourself and very introspective to come to terms with that. I have certainly made um, life-changing decisions for my for loved ones in my own circle. Um, and it's not an easy decision, but it's the right decision. But that can only come from knowledge of that person. And I don't think Americans are very good at talking about end of life care and comfort. And those decisions are made harder from that ignorance of what that person would want because everybody was uncomfortable with having a conversation. But it's almost, you feel like there's this, with cancer patient, I've had cancer twice already in my life, and everybody encouraged me to fight for my life. So what does it mean for the cancer patients for whom recovery isn't possible, if they say, I don't want this anymore, does that mean they're quitting? And it shouldn't be that kind of a paradigm. It shouldn't be that kind of a black or white. You're either fighting or you've given up. That's my personal pet peeve. You have to keep fighting. And oftentimes these people don't want to continue to fight, but they feel like they have to because they're doing it for their family. And in some ways, it feels like they're letting their family down if they say, I really don't think I can endure another round of chemotherapy or radiation or immunotherapy or another surgery or another blood transfusion. I just want this to stop. They don't feel validated in making that decision for themselves because they'd be letting everybody else down. That's terrible for me to think that people are doing that. Um, because there's still some shame with accepting death.
Yeah. Now I'm going to I'm going to switch gears a little bit. There have been several articles, one in the New Yorker, I'm sure many people are familiar with. It was very painful, and it's very painful to read, but discussing unethical behavior by some hospices, not the few. I mean, the majority, I believe, hospices are really upfront and transparent. Can you talk about what families should be aware of, what we should be looking for to make sure that we are using these hospices that are transparent, that are following the rules?
Yeah, that article was just devastating because as somebody who spent their career in healthcare and a large part of it now in hospice care, advocating for hospice, right? That there are flaws with it. We acknowledge that, we accept that, but it still provides a tremendous amount of help for an enormous number of people. So I was conflicted about those articles and the others that we've seen in the last year. Part of me was like, thank heavens, because now something will be done. Okay. We will divert more efforts into tracking them down, exposing them, shutting them down. We certainly need more regulations revolving around setting up hospice or any kind of care providing services. It does need to be more heavily regulated and monitored. We have to crack down on this proliferation of hospices in states like California and Texas who really it's despicable, and it takes us back, and it sort of leans into all of the myths that people hear about hospice, right? So one part of me was like happy to shine a light on it, but the other part of me was like, we've been fighting these myths for years, and this just feeds those myths that hospices are provide poor care, don't care about the patients, it's all about the money. And I also hate that it's attempting to drive a wedge, or the topic lends itself to sort of driving a wedge between not-for-profit hospices and for-profit. There are good and bad hospices in both. I know some excellent for-profit hospices who do wonderful work, and some not-for-profit hospices that maybe could do a bit better of a job. But hospice as a healthcare sector, we really do need to do a better job at policing ourselves and truly, you know, I feel that one way we can help protect patients and families is by educating them like we're doing today. This is what it should look like. If your care doesn't look like this, well, then maybe you need to raise your hand and start asking questions and questioning whether I made the right choice of provider. People only recognize the bad actors if they understand and are educated about what they are entitled to under the Medicare hospice benefit. And the Medicare hospice benefit, I keep referring to it as the Medicare hospice benefit because that's what it is. But it does provide the foundation of all hospice care providers in the United States. They all follow their rules and regulations and guidelines. So if you're with a hospice organization that, say, is not providing or making available 4 levels of care, you may want to look more closely into that provider. Every hospice should be providing what's called routine level of care. We have general inpatient level of care, respite care, and continuous care. If you ask them when you are signing those papers, or hopefully before you sign those papers, do you provide those 4 levels of care? And where do you provide inpatient respite and continuous care? And who will be providing that care? If they look blankly at you, you shouldn't be signing those documents. I know I listed a whole lot of things at the sort of top of the hour about what hospice services are provided. That was a long list. But if your needs are not being met, if you could benefit from a hospital bed, but one is not being offered you, or your loved one needs oxygen therapy, say, and the hospice provider encourages you to continue renting that equipment for yourself and paying it for yourself, they may not be a legitimate hospice provider.
So I'm going to ask two last questions. The first one is, how is hospice care evolving? Like, what would you like to see? What changes do you want to see within the next few years? And are we on our way to those? That's the first question.
I hope we are on our way to a better level of service. I think one of the biggest gaps in medicine that we have today that's somewhat silent, because we have an army of millions of unpaid family caregivers out there who are bridging the gap between people who could benefit from aggressive therapy and medical interventions and people who are eligible for hospice care. Hospice care was initially designed and developed specifically for cancer patients. Okay, that was the model it was catering to when it developed all of these surgeries. The prognosis and anticipated declines for cancer patients who are no longer receiving aggressive interventions is very predictable and relatively short-lived. So you can see, if you look at the model today, how it would really benefit those people. But now hospice care eligibility has been broadened so that hospice can take care of a far wider number of patient populations, including people with all kinds of dementias, where the prognosis is not predictable, or the decline's acute, and expecting them to manage those patients under the same parameters that they developed for cancer patients. So in between an Alzheimer or dementia patient becoming eligible for hospice care at truly end of life, end stage dementia, there is years of caregiving that is carried by family members, friends, people financially, taking on the burden of putting a loved one into nursing homes. Again, when they're severely debilitated but not yet eligible for care. It's an expensive route, and that expense is being shouldered by people sometimes who can least afford it. There has to be some transitional care that is funded, right, where they can receive relief, that the system is altered so that, you know, there are many people with terminal diagnosis, but their prognosis is undeterminable. What happens to them? They're falling through the gaps. We're seeing a lot of interest in hospital at home, you know, and other sort of extending the home health services. But it all boils down to, it being financed, and policy driving that.
Thank you so much, Angela, for being on the show today. The last question for those who want to learn more about hospice, what is the best way for them to do that? And how can they learn more about the HFA?
You can come along to our website at hospicefoundation.org. There is a lot of educational material on those pages. A lot of the benefits and, what hospice covers, what it doesn't cover. If you have any questions or concerns about getting a loved one into hospice, whether or not they're eligible, if they are indeed in a legitimate hospice provider, you can call us. If you go to the website, you can either call us, the phone number is there, or you can submit to our Ask an Expert services. And we can answer those questions for you. And if we can't answer them or I can't answer them, we know somebody who can. 9 times out of 10. So we're happy to do that for you. I've spoken to many people, mostly from California, I have to say, who had concerns about their hospice providers, whether it was a legitimate provider or not. I can help you with those questions, and hospice isn't an irrevocable decision. I mean, people come on hospice and decide it's not for them, and that's okay. You don't have to stay on hospice. I think a lot of people think that, it's not reversible. It certainly is, and it's certainly, you don't have to stay with an agency that you're not happy with their care, and you can transfer to a different hospice organization.
Thank you again. Folks, if there's one thing to take away from today's conversation, it's this. Hospice is not about giving up hope. It's about embracing the time we have left with dignity, comfort, and support. Whether you or a loved one is facing the end of life or you're simply planning for the future, understanding what hospice can offer is a powerful tool. It's about making informed decisions that prioritize quality of life. Thank you for joining us. If you have any questions, please comment below or reach out to me directly. And if you've found this conversation to be helpful, please like, share, comment, and subscribe. This is Traci Arieli from Comforting Closure, wishing you peace and comfort in your journey. Until next time, take care.